and thank you to GIS for giving me the opportunity to speak here. I'm representing the APSC. I have two disclosures. One, I'm not an interventional cardiologist, and second, I'm not presenting a case, but I will present a clinical study we published in Circulation last year, and I'll just share on a new collaborative network we have in the APAC region. So as we know, for our patients presenting with STEMI, we have timely primary PCI, but despite this, our outcomes can be improved. These are data from our infarct registry from Singapore, where we still have 11% death rates and heart failure rates of 7% at 12 months. And so there is a need for new treatments that can be given prior to reperfusion to see whether we can reduce infarct size and prevent heart failure in our patients undergoing primary PCI. Now, ischemia reperfusion injury is very complex. Comprises inflammation, microvascular obstruction, endothelial dysfunction, calcium overload, oxidative stress, and mitochondrial dysfunction. And many researchers, as you know, both in the preclinical and clinical setting, are looking for treatments to prevent ischemia reperfusion injury. So in this particular study, we looked at, this was the P2 trial called platelet inhibition to target reperfusion injury. We give our patients, as you know, oral P2Y12 inhibitors, but these do not offer maximum platelet inhibition at the time of primary angioplasty. And therefore, our STEMI patients were at increased risk of microvascular obstruction and myocardial reperfusion injury. So in this particular study, we tested Cangrelor as an IV platelet P2Y12 inhibitor administered prior to PPCI to see if we could offer maximum platelet inhibition at pre-PCI and also to see if we could decrease cardiomyocyte deaths. In preclinical studies, animal studies, Cangrelor had been shown to reduce infarct size and so may offer a dual cardioprotective strategy. So we hypothesized that Cangrelor administered prior to angioplasty will prevent MVO and reduce infarct size, and we used cardiac MRI to assess this effect. So this was a multi-center study in Singapore through 6 sites. 210 STEMI patients were randomized in the emergency medicine department to receive Cangrelor or normal saline fusion. And then we measured infarct size at day 3, day 4, and 6 months later we measured remodeling with infarct size and LV size and function. These show sort of 2 representative examples of MRI. MRI can be used to visualize edema, hemorrhage, as well as infarct size. So this top patient has an LAD infarct subendocardial, but no MVO or no hemorrhage, whereas this patient has a large infralateral infarct with a full thickness infarct here with edema, hemorrhage, and microvascular obstruction. So these are the results of this study. Unfortunately, Cangrelor had no effect on infarct size and no effect at 6 months on infarct size or remodeling. These are the data shown here, and the incidence of microvascular obstruction was no difference between Cangrelor and control, as well as the incidence of intramyocardial hemorrhage. Now, interestingly, we did a small sub-study to look at platelet function at different time points. But in those patients that had received Cangrelor, we could see that there was more effective platelet inhibition at the end of the pre-PCI procedure. But at the end of the Cangrelor infusion, the 2-hour infusion, there was no difference in the platelet inhibition, which will suggest that in these Asian patients in Singapore, the oral ticagrelor that is given may be able to offer sufficient platelet inhibition at the time of primary PCI, which may in part explain why the Cangrelor did not offer any protection on top or above ticagrelor. So this study was published in Circulation last year, and of course the question is why was there no cardioprotection with Cangrelor? Now we think, as you know, with clinical trials, you usually recruit the lower risk patients, so these are all-comer patients, all STEMI regions were recruited into the study, and it may well be that in our patients in Singapore, they're adequately inhibited with the oral ticagrelor. So this brings the topic on cardioprotection. This is an area of research which is quite disappointing in terms of lack of therapies for preventing reperfusion injury. Many different therapies have been tried: nitric oxide, targeted mitochondria, therapeutic hypothermia, beta blockers, ischemic post-conditioning, remote ischemic conditioning, and now antiplatelet agent. So why have these studies failed? I think it's a really difficult area to target reperfusion injury, and it could be our preclinical models that we use, our animal models are limited. We use animal models with no comorbidities, no co-medication. We usually target the cardiomyocyte, and we usually are testing in the clinical setting therapies that may or may not have been shown benefit in the preclinical setting. And of course, with our clinical studies, it's important to target, maybe consider targeting those most likely to benefit from a cardioprotective therapy, whether it's a patient with a large MI, presenting with a relatively short ischemic time and presenting with a fully occluded artery, so they undergo more significant reperfusion injury. We should only test therapies that have shown benefit in the preclinical setting, and the current gold standard is to use MRI to assess cardioprotection. So in the second half of the talk, I will just finish by sharing on a new network that we've established in the APAC region. This is the ASPIRE network, really to address the burden of cardiometabolic disease in Asia. So as we know, 60% of cardiometabolic deaths are in the Asian region, and incidence of CVD is set to double by 2050. And if you look at the global cardiovascular trials that are published in the literature, only 8% of the authors and the leaders in these trials are from the APAC region. And similarly, if you look at the patients recruited into these trials, only 8% are actually recruited from our region, which suggests that many of these studies are led by the US or Europe and are recruiting in Asia. So we wanted to address this underrepresentation by forming this network. So this is the ASPIRE network. So the idea is to attract global CV clinical trials and studies to the APAC region, to foster regional collaboration across the APAC, and of course to help with key opinion leader capacity building. So we have 12 regions across the APAC region with 36 members. These include Australia, Hong Kong, Indonesia, including several well-known interventional cardiologists, including Japan, Malaysia, and Mongolia. New Zealand, Singapore, South Korea, Taiwan, Thailand, and we do have Wael from UAE on this ASPIRE network. And we just launched this ASPIRE network in the Busan meeting in the Asia Pacific Society of Cardiology, and we jointly published our ASPIRE network in JACC Asia as well as the JAPC journal. And so now we're partnering, ASPIRE is partnering with the Asia Pacific Society of Cardiology. We're also partnering with a new Lancet Commission led by Stephen Nicol and Caroline Lam, looking to tackle cardiovascular death in the Pacific region. We'll be looking to undertake a multi-regional study in the APAC area, either as an industry-sponsored trial or an investigator-initiated trial. And we're looking at a multi-regional data collaboration. So we think with the network, the first collaboration that's relatively easy and straightforward is to do a data registry comparison, either infarction or heart failure. So we want to build strategic industry collaborations, attract funding, and undertake regional clinical studies and trials. So in summary and conclusion, rapid platelet inhibition using cangrelor at time of primary PCI did not reduce infarct size or prevent MVO in STEMI. There are many challenges facing the translation of cardioprotection into the clinic. And finally, the ASPIRE network is a new collaborative network which aims to foster collaboration and attract global CV trials to the APAC region. Finally, thank you for your attention.
Thank you very much.